Good morning, everyone. Uh, Thank you, Professor Sudeep Gupta sir and the entire organizing team for giving me this opportunity. It always feels great to come to this organization, this institute, which shaped the professional life. And I'll be speaking about two abstracts. The first one is radiotherapy to regional nodes in early breast cancer and individual patient data meta-analysis of 14,324 women in 16 trials. The background is radiotherapy has become much better targeted since the 1980s, improving both safety and efficacy. In breast cancer, radiotherapy to regional lymph nodes aims to reduce risks of recurrence and death. Its effects have been studied in randomized trials, some before the 1980s and some after. This meta-analysis aimed to assess the effects of regional node radiotherapy in these two eras. It's an individual patient data meta-analysis. The studies were randomized before 2009, and they were divided into two groups. The studies which started in 1961 and continued through 1978, and the second group which started in 1989 and continued through 2008. So if we see, there is a mean lean period of 10 years between these two groups. Radiotherapy versus no radiotherapy to regional lymph node, mainly the internal mammary chain, supraclavicular fossa, and axilla. Eligible studies included randomization or, in the Danish breast cancer group specifically, allocation by laterality, where they compared between left-sided versus right-sided tumors, in which only difference between treatment groups was the use or extent of nodal irradiation. EBC TCG's regular systematic searches of database including Medline, Embase, the Cochrane Library, and meeting abstracts, conference proceedings, plus extensive input from steering committee and collaborative group. The trials categorized according to radiotherapy technique, the older trials which started during 61 to 78, and the newer trials which started during 1989 to 2008. The main recurrence endpoint was therefore time to first breast cancer recurrence at any site, which includes locoregional recurrence, newly incident ipsilateral disease, or distant metastasis as first event. Death from an unknown cause before recurrence were assumed to be cause other than breast cancer. The stratification was done by age at entry, less than 40 years, 40 to 49 years, 50 to 59 years, 60 to 69 years, or more than 70 years. Nodal status classified as pathological node 1 to 3 plus or 4 or more plus. If pathological nodal status was unavailable, then clinically node plus or node negative or unknown status. Women with right breast cancer were analyzed as allocated to internal mammary chain radiation, and women with left breast cancer were analyzed as allocated to no internal mammary chain radiation in Danish trial. For heart disease mortality, analysis compared higher versus lower heart dose trial groups. The heterogeneity between the studies was assessed using a chi-square test. The result shows the data of 14,324 women in 16 trials, 8 new trials, including almost 12,000 patients, of whom almost 3,500 died, with a median follow-up 14 women years. The most common IMC versus no IMC radiation, that was the commonest pattern. IMC plus supraclavicular versus no RT was the second commonest pattern, followed by IMC plus SCF plus axilla versus no radiation. The 3 trials without IMC RT included SCF, axilla, or both versus no RT. In 8 older trials, the radiation technique used was direct anterior field. Most older trials did not include chest wall RT for node positive disease compared between regional nodal irradiation versus no RT. Pathological nodal status was available for only 51% in the older trials versus 96% in newer trials. 1.6% was BCS in older trials versus almost 57% in newer trials. And on that table, we can see that the distribution among the different nodal category. And in the bottom line, we can see that the incidence of first recurrence and the incidence of death from this cause. So regional nodal irradiation reduced overall breast cancer recurrence, which was significant, mortality, and reduced overall mortality as well. Absolute 15-year gains were 2.6% for any recurrence, 3% for breast cancer mortality, and 3% for overall mortality. IMC or SCF radiation should not cause lymphedema according to this trial's conclusion. The older trials, which began during 1961 to 78, included almost 2,157 patients, of whom 1,014 recurrences, 970 deaths, and 1,541 deaths overall, with a median overall follow-up of 25.6 women year. And these trials assessed radiotherapy to IMC, SCF, and axilla. The other trials assessed radiotherapy to SCF and axilla. In these trials, RNI did not reduce the breast cancer recurrence or mortality. However, it significantly increased non-breast cancer mortality, probably because of poor radiation technique. So to summarize in this study, radiation technique has improved over the last few decades. For women with negative lymph nodes, regional node radiotherapy reduced their absolute 15-year risk of breast cancer death by about 1 to 2%. Absolute benefit for an individual woman would also depend on other factors such as tumor size, grade, molecular subtype, and systemic therapy received. The proportional benefit of regional nodal radiation could be greater than those in the newer trials due to further improvement in radiation techniques. The absolute breast cancer mortality benefits could be somewhat lower than in the trials due to reductions in population breast cancer death rates. The second study is the updated result of AMAROS trial, radiotherapy or surgery of the axilla after a positive sentinel node in breast cancer. It's a 10-year result of the randomized trial. Initially, the study was published with a median follow-up of 5 years, and this present study reports the pre-planned 10-year analysis of the axillary recurrence rate, overall survival, and disease-free survival, and an updated 5-year analysis of morbidity and quality of life. So this is the study schema. Patients with clinically node-negative T1 or T2 primary breast cancer and a positive sentinel lymph node were randomly assigned between ALND or RT. The randomization happened before sentinel node biopsy to reduce the risk of error. ALND included at least anatomical level 1 and 2 and 10 nodes. The protocol of ART was 25 fractions of 2 gray per fraction or a biological equivalent dose to all the 3 levels of the axilla as well as the medial part of the SCF. Adjuvant axillary radiation after ALND was allowed when 4 or more lymph nodes were positive. So the primary endpoint was 5-year axillary recurrence rate defined as tumor recurrence in lymph nodes in the ipsilateral axilla, infraclavicular fossa or interpectoral area. The secondary endpoints were axillary recurrence-free survival, overall survival, DFS, as well as lymphedema, shoulder mobility, and quality of life. It was an open-label, multicenter, phase 3 non-inferiority trial. And we can see that the groups were well matched. The study was between 2001 to 2010. 800 patients underwent sentinel node biopsy. 1,425 were node positive and randomly assigned to either ALND or ART. The axillary recurrence occurred in 7 out of 744 patients undergoing ALND and 11 out of 681 patients undergoing axillary radiation. The 10-year cumulative incidence was 0.93% for ALND group and 1.82% for radiation group. There were 3 and 5 isolated axillary recurrences in both the groups. In total, 8 events occurred between 5 and 11 years of follow-up. Because of the low number of axillary recurrences, axillary recurrence-free survival and overall survival are almost the same, and that's why it was not reported. And if we can see here, the overall survival, disease-free survival are all comparable. And as per the final analysis, if we can see the morbidity and quality of life, radiation had a better quality of life, and the risk of lymphedema was significantly less in patients receiving radiation. However, the shoulder movement was restricted in this group of patients compared to ALND group. So to conclude, after a median follow-up of 10 years, after a median follow-up of 10 years, both the groups provided excellent loco-regional control for clinical T1, T2 breast cancer with positive sentinel node, with no difference in overall survival or disease-free survival. The updated 5-year data also confirm a significantly lower lymphedema rate after axillary radiation compared to surgery at all point of time. The prevalence of lymphedema in this study corroborates existing data, which ranges from 13% to 60% after ALND, which is quite high. So to conclude, after the initial publication of the AMAROS, ACOS-OG, and IBC-SG trials, The rate of ALND after positive sentinel node biopsy has decreased considerably. However, large practice variation still exists in the United States. The 10-year results of AMAROS trial confirm excellent long-term local and regional control and low morbidity after axillary radiation for patients with early breast cancer and a positive sentinel node biopsy. Thank you.